Checking out, checking. Checking. Hello. Hope I am audible. Hello. Yes, I am audible. So today we are going to discuss a session on FMG questions of surgery. December 2020 FMG questions we are going to discuss now. So good evening, Magesh. Welcome. So I am viewing you on another mobile. So any doubt you can always post in the chat because this is a YouTube session. Welcome, welcome Magesh, welcome. Good evening all. Set up ready. So we'll start the session now. So patient develops a lesion after 6 months of surgery. So diagnose this condition. Can you tell me what is the condition? You can answer this session in your chat box. You can answer. I'm viewing you what you're answering there. So this is a picture showing you a very classical picture of a keloid. Okay, this is a picture of a keloid. You have to understand what is the difference between a keloid and hypertrophic scar. I request you to understand the difference between a keloid and an hypertrophic scar. Okay. I'll tell you the difference between keloid and hypertrophic scar. This is actually not a hypertrophic scar. This is a keloid. So please understand the answer for this question is keloid. So keloid is seen at the level of very good. Sriveni, correct. That's a keloid. So keloid is seen arising from immature fibroblast. Please don't forget, keloid is seen arising from immature fibroblast. That is a problem with the writing pad. So sorry. That it arises from the immature fibroblast. So immature fibroblast, whereas hypertrophic scar arises from a mature fibroblast. And if this is a scar, it arises from beyond the scar. It goes beyond the scar. Keloid will go beyond the normal existing scar, whereas hypertrophic scar will not extend beyond the existing scar. Okay, let me open another writing thing. Because there is a problem in this. So keloid. So keloid and hypertrophic scar. Please know the differences. Some basic points you should know. Keloid is seen most commonly in the extensor surfaces. Very interesting point. Keloid is seen most commonly in the extensor surfaces. Hypertrophic scar is mostly seen in the flexor surfaces. Keloid will extend beyond the original scar. If you do a surgery, this is a surgery done, it will extend beyond the original scar. Whereas hypertrophic scar will be limited to the old scar. Keloid will cause severe itching. It will cause severe itching and it will extend into the normal skin. Whereas hypertrophic scar will not cause that much itching and it will not extend beyond the normal skin. And keloid cases are managed with intralesional steroids. Please remember, it is managed with intralesional steroids. Hypertrophic scars can be excised. It can be excision, can be done. So keloid you can do intralesional steroids or you can do intralesional excision. So we can excise it, but we should not go into the normal skin. We should excise it inside the skin, inside that margin itself. We should not go into the normal skin. So any doubt you have, always please post the doubts. I can answer your doubts there. So please, any doubts you have, please tell me the doubts. Okay. So keloid and hypertrophic scar, which will have strong familial tendency. Can you tell me which will have strong familial tendency? Keloids have strong familial tendency. They are more common in Negroes They are common in females. They have a strong familial tendency. Very interesting point is keloid is pre-malignant. It can go for Marjolin's ulcer. Keloids can get converted to Marjolin's ulcer. Very interesting point. It can go for malignancy, that is Marjolin's ulcer can arise from keloids. Okay. So please don't forget this point about keloids. So next second question is very simple question. So actually the questions this year in FMGE exam, especially the December FMGE exam paper, is very simple paper, and most of the students, they were scared seeing the old paper of June paper. Most of the students were very much scared while appearing for the exam, but finally what happened is the paper was very easy, more of image based session. The session is most of image based from surgery, and most of the questions are easily answerable for your exams. So what is this ulcer? Can you identify this ulcer? This is a case of venous ulcer. Okay, please don't forget this is a case of venous ulcer. Okay, this is very good. That's a venous ulcer. Let us discuss about the venous ulcer. So venous ulcers are seen most commonly in the medial malleolus area. Please don't forget, venous ulcers are most commonly seen in the medial malleolus. Okay, this is the most common site of medial malleolus only. It's most commonly seen or the medial malleolus. This area is known as gaiter area. Please don't forget, this area is known as gaiter area. So gaiter area is the area which we will hold your legs while you are doing a horse ride. This is a gaiter area. This is the most common site of venous ulcer, and venous ulcers are usually sloping ulcers. They have a sloping ulcers. The floor is covered by granulation tissue. The floor is covered by granulation tissue and it bleeds. If it bleeds, what is the treatment? This is an expected FMG question. If a varicose ulcer bleeds, what is the treatment? Yes. If a varicose ulcer bleeds, immediately you should ask the patient to lift the limb. Lift the limb. No need to go and do a tight compression and all. Just you ask the patient to lift the limb. As you lift the limb, the bleeding will stop. That's the most important thing I want to tell you here. As you lift the limb, the bleeding will stop in a case of varicose ulcers. Okay. So the varicose ulcers and pressure ulcers, if you see the differences, it's very simple. You have to know the differences between varicose ulcers and pressure ulcers. Very important point for your exams. Let me tell you that, don't worry. So differences between varicose ulcers and pressure ulcers. Varicose ulcers and pressure ulcers. Sorry, there's some problem. OBS software, it's really difficult to do. So I'm now picking up the varicose ulcers. So don't know, most of the students don't know. I think there's a class going on. I also didn't do much of posting in many places because this is my last class in Unacademy, and anyhow this is going to be available as a recorded session. So only 6 students came for the class. I don't know why. Yes, Sachit, there are only 6 students. So varicose ulcer versus pressure ulcers, let us discuss. And also this session is being discussed very late. This session exam was over long back. Now we are discussing after a long period. So mostly the students would have attended the session somewhere else. So somewhere else in some other platform they would have attended the session. That's the reason. So varicose ulcer and pressure ulcers, you have to know the differences. Varicose ulcer is most commonly seen over the medial malleolus. That's the first point. So from the point you should know the difference. It is most commonly seen over the medial malleolus. Pressure ulcer is most common in. Pressure ulcer is also known as a decubitus ulcer. Actually, what I think Magesh wants to know is not about the decubitus ulcer. What you are thinking in your mind is about the tropical ulcers. Tropical ulcers. So tropical or neuropathic ulcers. I hope you want to know. So neuropathic ulcers are mostly due to loss of sensation in the foot. So they are most commonly seen on the medial. So they are seen on the sole of the foot over the great toe area. Over the great toe area, there is a tropical ulcer seen. Actually, there is one session of me, all ulcers explained in detail in Unacademy. Old special class session is there. So this is associated with loss of sensation. It is mainly neuropathic ulcer is due to loss of sensation, and probably they have an associated loss of blood flow also. So they have a loss of blood flow also. And neuropathic ulcers are usually punched out ulcers. They are usually punched out ulcers. Whereas varicose ulcers are usually a sloping ulcers. Sloping ulcers. Yes, Sachit, I am from Tamil Nadu only. So I hope you are a FMG student. So please attend these classes. Just a 1 hour session. I will give a fast review. So varicose ulcers have sloping edge. Tropical ulcer and neuropathic have a punched out ulcers. So when you go for a decubitus ulcers, actually Manish is asking about the decubitus ulcers. So decubitus ulcers, where are they seen? They are also known as pressure sores. They are mostly due to long period of lying without any movement. They are most common on the ischium. They are most common on ischium. Ischium is the most common site for pressure source. Ischium followed by greater trochanter are the sites where you get a pressure source. Okay, so discuss about it in some other sessions in detail about the pressure source. Let us come to the topic. So this is the second question. Simple question. The third question: a pregnant lady on routine ultrasound showing the following diagnosis. What's your diagnosis? So very classical picture you are seeing here. Very classical picture. The picture is showing you a gallbladder. Please remember, this is a picture showing you an area of gallbladder with a multiple. You can see multiple stones. There are multiple stones. Why I am saying these are stones? Because in stones there is what finding seen. What is this known as? Yes. So what is the finding seen in? What is the finding seen? Yes, this is a gallstone. What is the finding of gallstones? Please tell me. What is the finding of gallstones? Yes, the gallstones and gallbladder polyp. I want you to know the differences between gallstones and gallbladder polyps. So gallbladder polyps and gallstone, the main differences you have to know about the video is clear only. But I am seeing in another laptop. Just verify your net. I am seeing in another laptop. It is clear only. So gallstones and gallbladder polyp. So this is a gallstone and this is a gallbladder polyp. I am going to tell you the differences between these two in an ultrasound. In a gallstone, if you throw the ultrasound, it will show you posterior acoustic shadow. This is a picture showing you posterior acoustic shadow. Very interesting shadow, posterior acoustic shadow. That is a classical image shown in your picture. Patient is having multiple stones showing you posterior acoustic shadow. And gallbladder polyp, the polyp is shown here. The polyp will not have no posterior acoustic shadow seen. And most importantly, the posterior acoustic shadow gallstone will move with the changing of position. If the patient turns one side or another side, the stone will move. Whereas this polyp will not move. That's the second point. Will not move on changing of position. So please remember, on movement of the patient, the polyps will move, will not move, stones will move. Okay. So this is a picture showing you a classical picture you are seeing here. You can see the classical picture. You can see the picture of a polyp. You can see this is a polyp. There is no posterior acoustic shadow. This is a stone. You can see the typical posterior acoustic shadow. This is a classical finding to differentiate gallbladder polyp from stones. Okay. So please find the answers. Very simple questions only asked in the exam. A patient has ultrasound finding of gallstone abutting the cystic duct with the dilatation of common hepatic duct. What is the most likely diagnosis? So all these questions are very basic, simple questions which are commonly asked FMG questions as one-liners. Once upon a time they will ask these questions as one-liners. Now they made it as small clinical based questions. That's all. So what is the most likely diagnosis of this case? Yes, tell me. Acute cholecystitis, porcelain gallbladder, GB polyp or Mirizzi syndrome. So what is the finding? This finding is showing an ultrasound of a gallstone abutting the cystic duct with the dilatation of common hepatic duct. What do you think will be the finding? So here the finding is very simple. This is a gallbladder. The gallbladder, there is a stone. This stone is compressing the bile duct. Please remember, this stone is compressing the bile duct like this. So this syndrome is known as very good, Rajinikanth, very good. It's perfect. That's a Mirizzi syndrome. Please don't forget Mirizzi syndrome. You should not forget Mirizzi syndrome. Mirizzi syndrome is a condition in which a stone in the gallbladder will compress the bile duct and it will cause obstructive jaundice. So which will cause obstructive jaundice. The stone will compress and it will cause obstructive jaundice. Okay, this is the point here. So which is hard, by good, everyone, every exam is same. Hardness depends upon the preparation. That's all. Every exam is same. NEET PG or FMG, both exams are same paper only. The way you prepare, it is going to be different. So if you are going to prepare perfectly, NEET PG and FMG both are same exams. They both are same. You can easily, FMG students, all FMG students, you can crack NEET PG within the same attempt after clearing FMG. So you have to develop that confidence to crack the NEET PG the same attempt, okay. So now the next question is, a man presented with vomiting, nausea and fever. He was admitted for appendicectomy after diagnosing appendicitis. So please understand, he was diagnosed as appendicitis and appendicectomy was about to be done. During surgery, the surgeon find out an incidental lesion which was present at 2 feet distance from the ileocecal junction. What will be the diagnosis? Yes, tell me. Magesh, it's not D. What is the answer here? It is not D. It is not appendicitis. What is the answer here? There is a classical picture showing you a lesion. It's a classical picture showing you a lesion found on the anti-mesenteric border. Please remember, it is found on the anti-mesenteric border. Very important point. It is found on the anti-mesenteric border. It is a true diverticulum. It is known as Meckel's diverticulum. So it is known as Meckel's diverticulum. It is seen on the anti-mesenteric border. You should not have any doubt in these type of questions. These are very basic questions, simple question. You should not have a simple doubt also. These type of questions, if you make mistake, there will be no excuse at all for you in the exam. This is a 2 feet distance. That answer, that the clue is here. That is rule of 2. What is rule of 2? Please don't forget rule of 2. Whenever they tell Meckel's diverticulum, there will be always a rule of 2. It is present in 2% individuals. It is how many inch length? It is 2 inch in length, not 2 centimeter. Okay, it is 2 inch in length. It is 2 inch in length, and it is present 2 feet proximal to ileocecal junction. It is present 2 feet proximal to ileocecal junction. Okay, it is present 2 feet proximal to ileocecal junction. It is 2 inch in length, 2% individuals, 2 feet proximal to ileocecal junction, and there are 2 ectopic mucosa seen. That's our third point. That's actually not a real 2, but that we made it as a real 2. 2 ectopic mucosa are common. What are they? What are the 2 types of ectopic mucosas commonly seen in this? The ectopic mucosa commonly seen are, one is gastric mucosa. Okay, one is gastric mucosa, another is gastric mucosa, and another is pancreatic mucosa. Pancreatic mucosa. Okay, there are 2 mucosas in. Very good, Rajinikanth. There are 2 mucosas. One is gastric mucosa and another is pancreatic mucosa. Young male on exposure to severe cold developed color changes in the finger repeatedly and landed up to your clinic with these findings. With the findings of, you can see the findings, the fingers are gangrenous. The fingers are, tip of the fingers are gangrenous, and this patient is getting exposed to cold. What is your diagnosis? Yes, what is the diagnosis from this picture? It's a Buerger's disease, Raynaud's disease, TAO, atherosclerosis. What is the answer here? No, it's not Buerger's. Buerger's is commonly affecting the lower limb, but to file. Thank you, Sachin. Sachin, please attend the class. It's a small session. You will have another session soon in another platform. So this is a small session. Please attend the classes. So this is a picture showing you a case of Raynaud's disease. Please understand what is Raynaud's disease. So actually the choice the people told that was given as systemic sclerosis was there in the choice, not Raynaud's there. So if systemic sclerosis is there, that is also a correct answer, because you can see the Raynaud's phenomenon is characterized by 3 colors. There will be initially vasospasm. That is because of the exposure of cold, the fingers go for white color. First picture you can see the fingers are in white color. Then the veins alone open, the arteries will not open. The veins alone will open, arteries will not open. That results in typical finding of bluish color change. That results in bluish color change of the fingers, and there will be reperfusion, that is a red color change. So white, blue, crimson, red. These are the 3 colors: white, blue, crimson, red. Very good. So treatment temperature for frostbite is a repeat question. By good, it is 42 degrees centigrade. We have to rewarm the patients with the rapid rewarming at 42 degrees centigrade. So what is the correct answer for your question? It's a nice question, but it is a NEET PG question, not asked in FMG exam. So please be thorough with that question. It is 42 degrees centigrade for frostbite. So this is the 3 things will be seen: white, blue, crimson, red. Okay, rewarming temperature, treatment temperature is 42 degrees centigrade. So this is Raynaud's phenomenon. Here there is no role of rewarming at all. In Raynaud's phenomenon there is no role of rewarming. We should avoid cold exposure. Slowly it will get recovered. So many people will always ask, what is the difference between Raynaud's disease and Raynaud's phenomenon? So Raynaud's disease is nothing but a primary condition in which the etiology is not known. Raynaud's phenomenon is due to secondary. Some etiology is there. What are the features of etiology of Raynaud's phenomenon? So please remember Raynaud's disease and Raynaud's phenomenon, clinical feature will be same. They present to you with the white, blue, crimson, red color. Raynaud's disease is known as primary. They are known as primary disease. They don't have a known etiology. Secondary is known as Raynaud's phenomenon. So phenomenon or syndrome is secondary. It is secondary. What are the causes of secondary Raynaud's? So atherosclerosis, drugs, some cancer drugs, SLE, scleroderma, Sjogren's, rheumatoid arthritis, smoking, repeated injury or usage, all these things can cause secondary Raynaud's, that is known as. Why could you follow what is there in Bayesian law? Because the question has been asked in Bayesian law. That question is from Bayesian law. That is a clear-cut line. What is the rewarming temperature used? And the question choice also came as 42 degrees centigrade. They didn't give a value of 37 to 40. Rapid rewarming at 42 degrees centigrade is a line from Bailey. You follow that, okay? So Dolman's procedure is used for. So Magesh, that's not most commonly not that what you are telling. Smoking is for Buerger's disease. Buerger's disease is a separate disease. It is disease involving the lower limb. Don't get confused with the Buerger's and Raynaud's. Buerger's disease is totally different. That is associated with smoking. Okay, don't get confused with Raynaud's. Raynaud's is most commonly associated with cold exposure. The point is, many people will be asking, what is Raynaud's disease? What is Raynaud's phenomenon? Raynaud's disease is primary. Raynaud's phenomenon is secondary. Secondary means a known cause like this is present. So classical question, Dolman's procedure is used for. This question is being a repeated FMGE question. More than 100 times this question has been asked in the exam. So Dolman's procedure is used for. What is your answer? Very good, Rajinikanth, very good, perfect. So the answer is pharyngeal pouch. That's perfect answer. The answer for this is pharyngeal pouch. This is a pouch. This is esophagus. So let me now write because this writing on this is not showing so clearly. So I'll open the OneNote for writing it. So now please understand what is Dolman's procedure. It's a very classical question. For a pharyngeal pouch, this is a cricothyroid muscle. Please don't forget, this is a cricothyroid muscle. This is cricothyroid muscle, and this is a Killian's dehiscence here. This is a Killian's dehiscence here through which the pharyngeal pouch arises like this. This is pharyngeal pouch. So please don't forget, pharyngeal pouch is most common posteriorly. The posterior triangle, it is most common in old men, and it is common in the posterior triangle. It is a false diverticulum. It is not containing all layers. So usually we will do a variety of treatment is there. We can do diverticulectomy. We can cut and remove the diverticulum, or we can put a stapling between this esophagus and this diverticulum by one staple technique. That stapling technique is known as Dolman's operation. So Dolman's operation is known as stapling technique. Yes, very good. It is also known as Zenker's diverticulum. Actually, it is known as Zenker's. Very few people call it as pharyngeal pouch. Most of us call it as only Zenker's diverticulum only. So the Dolman's operation is between the diverticulum and the esophagus. We will make a stapling, that is known as Dolman's operation. I'll show you that image. This picture is a picture-based question also. This question has also come in the picture-based question. Yes, very good, boy. That is most common on left side, posterior triangle, most common in old age. That's perfect. Yes, that septum is joined. This septum will be joined. That's a treatment in Dolman's. In Dolman's, what is being done is this septum is joined like this. The septum together will be joined because of this stapling technique. So this is typical thing. It is not pseudo. We call it as false diverticulum. We don't call it as pseudo diverticulum. It is a false diverticulum. So which of the following is not a natural constriction of esophagus? Which of the following is not a natural constriction of esophagus? So I hope you all know esophagus. There are 4 natural constrictions when you do a barium swallow or an endoscopy. What are the 4 natural constrictions? So we call it as 15 centimeter, that is a natural constriction. 20 centimeter, that is a natural constriction. Yes. What are all the, 15, 25 centimeter and at 40 centimeter. So this 25 and 27 are the 2 points. 15 centimeter is cricopharynx. 15 centimeters cricopharynx. 25 is arch of aorta. 27 is left bronchus. Left bronchus compresses at 27 centimeter. 25 centimeter arch of aorta seen. 40 centimeter is OG junction or diaphragmatic compression. So these are the natural constrictions in esophagus. So Thyroid position is not a compression. Okay, thyroid is not a position for esophageal compression. Please remember this point. So finally, around 18 students have joined this. So we are this some of you who came new. Just we are giving a fast review of the FMG surgery questions. Around 25 questions came in the exam. So I'm just giving a fast review, question and answer. So with these questions, you should know that which are all the areas you should concentrate. So from the FMG exam December, they have proved very clearly they will not go out of syllabus. They will be always restricting themselves to the questions which are very familiar for FMG exams. They have asked all the questions from familiar topics only. So please don't get scared. Yes, 25 questions come usually in NEET. Usually you will get 40 questions from surgery. Last year around 50 questions came in surgery from NEET, but in FMG exam they give proper distribution. Around 25 questions came in the surgery, and all the questions are standard questions. And I'm telling you guys, don't get scared about the people creating scare like this paper is becoming tougher, the syllabus is changing, everything is becoming tougher like that. Don't get scared. Nothing will change. It is easy only. Once you go with the confidence, paper will be easy. You'll answer easily. Once you go with the fear, oh, the paper will be different, there will be more of clinical based questions, all those things will unnecessarily create a panic among you, and you will forget most of the basic things which you know in the exam. When you go just like that, very casually, you can answer all the FMG questions. FMG questions, examiners are not so much psychopaths to make you a tough question like an INI common entrance. They just want you to clear the exam, just like a final MBBS student clears his final year exam. So definitely, if you go with the confidence and with the no fear, you will easily clear these exams. Okay. So what is this instrument shown here? So I will be giving you one PDF of all the scoring. Don't worry, by good. I will give you all the PDF of scoring. So this is a typical picture showing you what is the diagnosis here. What is this diagnosis here? It is Babcock's forceps, 100 times asked MCQ. So you can see this score grading and all. You may not remember everything. You can see the name only. They will ask you in FMG exam. They won't ask you what is the score and all in FMG exam. NEET PG, they may ask you the scoring things. I will have a separate session in my YouTube channel on the scoring systems. So don't worry. I'll give you easy method to remember before your exams. This is a Babcock forceps used to hold appendix and bowel. So you can see the other instruments also now. So this picture is showing you what is this instrument known as. Yes, what is this instrument? Yes, what is the first instrument? Please tell me what is the first instrument. That is a Alice. Please don't forget that is an Alice tissue forceps. The second instrument is Coccus tissue forceps. The third instrument is ovum tissue forceps. Ovum forceps is used to remove the tissues from the endometrium, to hold and remove the tissues from the endometrium. So Coccus is a sharp instrument, single tooth is present. Coccus will have a single tooth. Alice will have multiple tooth. Coccus and Alice you should not be using in soft structures like bowel. Coccus and Alice are used only to hold the fascia. You should not use in the bowel. Please don't forget that point. It should not be used in the bowel. They should be used only on the soft tissues. Okay. So very simple question here. Identify the stoma shown in the right iliac fossa. What is your answer now? What is the answer now for this question? Identify the stoma shown in the picture right iliac fossa. Yes, what's your answer? Waiting for your answer, guys. Please tell me. So you can see there are two openings. You can see there are two openings. 1, 2. Before that, they have told it is right iliac fossa. We keep only ileostomy in the right iliac fossa. Please remember, either it will be a loop ileostomy or a end ileostomy. So from the site of the abdomen wall itself, you can say where they have kept the stoma. I will show you simple method to remember where the stoma is. So please remember ileostomy and colostomy from this picture. This is an abdominal wall. Okay, this is an abdominal wall. Ileostomy is always created in the right iliac fossa. It can be either a ileostomy like this. The ileum can be brought out like this, known as end ileostomy. Or it can be brought out of the abdomen wall like this as a loop. So this is known as loop ileostomy. In loop ileostomy, you can see this lumen and this lumen. So loop ileostomy. So end ileostomy and loop ileostomy main differences. End ileostomy is complete diversion of the food particles or complete diversion of the motion. So loop ileostomy, there is a partial diversion. Some food particles or something can go like this also. So it's a partial diversion. Partial diversion. So this is end and loop ileostomy. Okay.
SOS Hospital.
So partial or end ileostomy. Hello. அம்மா என்னம்மா விஷயம்? நான் கிளாஸில் இருக்கேம்மா, முக்கியமாக நான் திருப்பி கால் பண்ணுறேம்மா. நான் ஓகே. So this is a loop colostomy. You can see the loop colostomy, the colon, transverse colon. Usually the loop colostomy is created in the epigastric region. And end colostomy is created in the left iliac fossa. So I hope you all have our workbook. All the workbooks have our images. All the images are there in the workbook, so you can see all the workbook images. All the images I have uploaded in the workbook. So please remember loop colostomy and end colostomy. Loop colostomy, end loop. So these are the things, various things. From the picture itself, you can see where they are seen. So in the right iliac fossa, we constitute the ileostomy. Epigastric region, we create the loop colostomy with the transverse colon. In the left iliac fossa, we use the sigmoid colon in the left iliac fossa. Okay, sigmoid colon is used as a end colostomy in the left iliac fossa. These are very classical points you should not forget for your exams. So there are so many points, interesting points from this. Yes, you can do it in perforated terminal ileum, and we can use it as a covering procedure. When we are doing an anterior section in the distal end, you will do this as a covering procedure. You will be knowing that in detail soon. So a player injured with a ball and suddenly loses consciousness. Okay, a player plays with the ball and suddenly loses his consciousness. When one of the entire teammates come for helping, he gets himself up and starts playing again. He is again playing. During tea break, the person was again unconscious while his friend saw him. Immediately he has been rushed to the hospital. What will be the diagnosis? The history shows you what is the history. The history is giving you what? Yes, very good. That's what you are telling is correct. EDH is correct. What is the history shows you? The history is related to lucid interval. Please don't forget, this is a picture showing you a lucid interval. This is related to lucid interval. Yes, lucid interval is a classical feature of this cases of EDH, extradural hemorrhage, will cause lucid interval. Okay, this is a classical EDH. What will be the CT finding? CT scan finding will be biconvex shaped hematoma like this. It's a biconvex hematoma. You can see the biconvex shaped hematoma. Okay, biconvex shaped hematoma can be seen in an EDH. If it is a SDH, you will see a hematoma like this. Concavo-convex hematoma in SDH. EDH is due to rupture of EDH can have rupture of he will have rupture of middle meningeal artery. Yes, Ali Raza, even chronic SDH can have a lucid interval, but this case is an acute case. No, within playing he has come to you immediately. So acute EDH only will have more common chance of lucid interval. Chronic SDH also can cause lucid interval, but we specifically call EDH only for lucid interval. Okay. So that is very rare. That may be such a long 1 month difference will be very rare. Why? That's very difficult. So EDH is convex. No, EDH, extradural hemorrhage, is convex. You need not mug up these things. When you mug up, no, you will forget. Why EDH is biconvex? It is biconvex. Why? Because this is a skull. This is a meninges. So meninges can be easily compressed by the hematoma. Meninges can be compressed, and this will form a extradural shape like this. So form a biconvex shape like this. Whereas here the meninges are here. One side the meninges will be here. Another side the brain is there. So what happens? Therefore they get a concavo-convex appearance. They get a concavo-convex appearance. So I think some of the NEET PG aspirants also here. NEET PG exams probably in April or in the May. Not before March, no doubt, because they have postponed the date for PG aspirants, so it's not before March. Okay. Subarachnoid hemorrhage CT scan is easily diagnosed only by seeing the cisterns. Subarachnoid cisterns, you should see the contrast. You have to verify the images. I have put the images in my workbook. I will try to show you the images one day separately. So which of the fluid is not advised during intracranial injury? Can you tell me which of the fluid is not advised during intracranial injury? So intracranial head injury, the ideal fluid is what? Please tell me first. What is the ideal fluid for an intracranial injury? The ideal fluid for intracranial injury is mannitol. Mannitol is ideal fluid. And we can also use hypertonic solutions. Any hypertonic solutions you can use. You should not use hypotonic solutions and glucose containing solutions. Hypotonic and glucose containing solutions will cause cerebral edema, and that will cause increased intracranial hypertension. So which fluid should not be used is 5% dextrose is the fluid that is contraindicated. Please remember, as answer here is 5% dextrose. Ideal fluid used in intracranial head injury is mannitol. We should not use in head injury Glucose containing fluids and steroids. These both are contraindicated in head injury. So steroids and glucose containing fluid should not be used in head injuries. So please don't forget this point. So patient was brought to emergency department and IV transfusion has to be done as his BP is only 90/60. Pulse rate is 110. Which color IV cannula should be used? This is a very classical question. Many students would have marked this as grey, seeing the old MCQs. So there is an old MCQ showing grey as many times asked. So grey is 16 gauge. Okay, grey is 16 gauge in which we can push 200 ml fluids per minute. 200 ml of fluid can be pushed in grey when flan in 200 ml per minute. In this question, there is an interesting point, though we don't see in hospitals orange color. Orange color is 14 gauge. You see, this is the 14 gauge. 14 gauge, I can push 250 ml per minute. Very interesting. 250 ml can be pushed in red, not green. Many of you have answered green. I don't know why. So many of you answered as grey in the exam. That is totally wrong. So which color cannula? Actually, the question was which color cannula has to be given is not the question. Which color cannula we can provide maximum fluids? That's the question. Question is which color cannula maximum fluids can be produced. The maximum fluid can be produced with the orange cannula. First, second grey, third only is green. Okay, this is the order 1, 2, 3. So grey is 16 gauge, only 200 ml. When you see for green, it is only 18 gauge, only 80 ml can be pushed. 80 ml per minute can be pushed. So pink is 20 gauge, 22 is blue, 24 is yellow. Pink, blue, yellow. So this cannulas you should not forget. Cannulas are repeat questions for your exams. So please be thorough with the cannulas, especially 14 gauge is orange, 16 gauge is grey, 18 gauge is green. 14, 16, 18 don't forget, because usually they put the question only from this 3. And last year the NEET PG question came from pink cannula. What is the size? Pink cannula is 20 gauge cannula is the pink cannula. This is pink. So please remember the cannulas. Cannulas are important for your exams. So now a very basic question, very practical questions. Best method to check the correct placement of central venous catheter. So in the internal jugular vein, I want to know whether the catheter is correctly placed in the internal jugular vein and it is going towards the superior vena cava. What is the best method? Can you tell me what is the best method to know the correct position of the cannula, central venous catheter cannula? Yes, very good. It is actually chest X-ray, not CVP. Okay. So you can see Magesh is asking which cannula where it is used. This yellow is used in newborn ward. Once you go to hospitals, you will see that yellow is used in newborn ward, blue used in pediatric wards, pink and green used in general wards, grey and orange are used in trauma centers. Grey and orange are used in trauma and in anesthesia places. So it's very simple. Pink and green are used in practice in general wards, blue for pediatric ward, yellow for newborn ward, orange for trauma and anesthesia purposes. Orange and grey are used. Okay. Yes, this can be definitely repeated. Best method to check the correct placement is by means of X-ray, not by any other method. You have to check its X-ray, chest X-ray. So you can see this is subclavian vein being inserted. It has wrongly gone into above. It should not go above. It should go like this. No, it has wrongly gone above. This is what we see. We will look for malpositioning of the cannula. If you see if it is going like this, how can I give a total parental nutrition? It is wrongly positioned cannula. This is the position showing you wrong positioned cannula. You have to take X-ray to look for the position, not only for the position but also to look for what? X-ray chest is done to look for one position of the tip. Number two to look for pneumothorax. Okay, number 2 pneumothorax. So diarrhea and dehydration minimum you should use green when flan. Diarrhea and dehydration minimum you should use green when flan, and you can even go up to grey when flan also. Nothing wrong. You can look for also grey when flan. 25-year-old male patient presented to trauma center with a BP of 80/40, respiratory rate of 25 per minute. On examination, there is an hyperresonance in the right side chest. Chest X-ray shown below. What is the appropriate management? So you can see this is a picture, classical question. It is a case of tension pneumothorax. It's a case of tension pneumothorax. You are noting here. Tension pneumothorax, what we do? I will immediately put a wide bore needle followed by ICD. That's the correct answer. What is appropriate management they are asked? They didn't ask you what is the first treatment. First treatment is putting a wide bore needle in the fifth intercostal space. Appropriate treatment is putting a wide bore needle in the fifth intercostal space followed by ICD. This question is also a case of INI common entrance test question. This question came in INI common entrance test, and the FMG guys, they copied this question from a INI common. Same question came. So please remember, sometimes the questions from INI common entrance test may be asked in FMG exams. Okay. So this is a classical picture showing you what is the image showing you here. What is this image shown here? Yes, that's the image question asked in INI common entrance test and in FMG also. So I got these questions from Arise Academy. All these questions I got from Arise Academy people. So they gave me the question paper for discussion. And actually, just half an hour before starting the session, they gave Dr. Khalil sir from Arise Academy sent me a updated question paper. So soon I will do an updated question paper session because they have given the Pakka question paper with all the explanations they have sent me recently. So diagnose this condition shown below. Yes, what is your diagnosis? Very good, Rajinikanth. Very good. Very good. It is a annular pancreas. So annular pancreas, what is the presentation of annular? I'm not discussing each condition in detail because it's not the time will not be sufficient for me to discuss everything. But let me tell you the important points alone. Annular pancreas is due to failure of rotation of what? It is due to failure of rotation of ventral bud of pancreas. Very interesting first word. So once you have got now a question from annular pancreas, in future you can get more questions from annular pancreas. So please understand what is annular pancreas. This is a duodenum, and you can see this is a dorsal bud of pancreas, and this is ventral bud of pancreas. This is ventral bud, this is dorsal bud. Usually what happens according to embryological thing, this ventral bud will rotate and come here. If it doesn't rotate, if it fails to rotate, failure of rotation of ventral bud, that's a pathology. Failure of rotation of ventral bud results in annular pancreas. Failure of rotation of ventral bud results in annular pancreas. Please don't forget this point. It results in annular pancreas, and this results in vomiting. It will result in bilious vomiting, not non-bilious. It will result in features. It will slowly go for obstruction like this, and these kids or these patients will develop bilious vomiting. There will be bilious vomiting. So what you are telling, non-bilious is for congenital hypertrophic pyloric stenosis. These guys develop bilious vomiting and typical features of GOO. So these guys will show you double bubble appearance on X-ray. And treatment is duodenostomy is a treatment, or duodenojejunostomy is a treatment for these cases. So annular pancreas are treated by duodenostomy or duodenojejunostomy. So the same pathology, what happens here? This ventral bud rotates and comes here, but does not fuse with the dorsal bud. This is dorsal bud, this is ventral bud. Failure of fusion is known as pancreas divisum. This is most common. Failure of fusion is known as pancreas divisum, and this is most common than annular pancreas. So failure of fusion is known as pancreas divisum. Okay, they present with recurrent acute pancreatitis. Please remember, they present with recurrent acute pancreatitis. Those cases are presenting to you with a recurrent acute pancreatitis. Most important point for your exams. So please don't forget this question. There are so many questions. Let us go fast. You can see this is a picture showing you a double bubble appearance. You can see the picture of double bubble appearance, stomach and duodenum. This is seen in duodenal atresia and annular pancreas. This is a picture showing you single bubble appearance. Where will you get a single bubble appearance? Can you tell me? Single bubble appearance on X-ray. The second picture is showing you single bubble appearance. Single bubble appearance. Most of you would have not heard this MCQ. It is congenital hypertrophic pyloric stenosis. Will have a single bubble appearance. Okay. It is having a single bubble appearance. Don't forget this. 5-week-old male child is brought to emergency with the multiple episodes of non-bilious vomiting. Some of you told about non-bilious. No, here comes that question. It's a non-bilious vomiting. Identify the barium image and diagnose the condition shown here. This is a picture showing you a pyloric stenosis. Very good. This picture is showing you a string sign. You can see here there is a string sign on barium. String sign on barium. And second picture is showing you a mushroom sign. This is a mushroom. You can see the mushroom. It looks like a mushroom. No, so it is known as mushroom sign. None of this test is needed nowadays because we have ultrasound is the investigation of choice now. Latest answer for this is investigation of choice to diagnose congenital hypertrophic pyloric stenosis is ultrasound abdomen, but nobody is using now barium meal, and also just for MCQ, barium meal showing you string sign, barium meal showing you mushroom sign are shown here. It is a case of congenital hypertrophic pyloric stenosis. Okay. A male patient presents to OPD with an abdominal lump in the periumbilical region that moves at right angles to attachment of mesentery. What is your diagnosis? Yes, what's your diagnosis? You will not have a doubt at all for bird's beak and rat tail. You can see from the image itself, you can see what is bird's beak and what is rat tail. Let me show you by drawing. I didn't have the picture now, but I'll show you by drawing. So you must not have a confusion between bird's beak and rat tail. So please remember, bird's beak is an absolute cutoff. After that, no contrast flows. This is bird's beak. So when you do a barium swallow, there is an absolute cutoff. No further contrast flow. No contrast flows distally. It is known as abrupt cutoff. It is known as abrupt cutoff. This is known as bird's beak. So please remember, bird's beak is more of achalasia. Rat tail is not like that. Rat tail is a picture. This is a rat. You see the picture of rat. The rat tail, the body of esophagus is dilated. There is a shouldering effect in the lower part of the esophagus. Actually, the cancer is in these places. There is a shouldering effect, also known as tapering effect. So there will be slowly contrast will flow like this. This is known as rat tail appearance. It is mainly due to cancer. It is due to cancer. Okay. So please don't forget this thing. So this point you should not forget. This patient comes to you with abdominal lump in the periumbilical region that moves perpendicular to the mesentery is chylolymphatic cyst. I want to tell you what is chylolymphatic cyst. I hope you know what is chylolymphatic cyst. So please don't forget, chylolymphatic cyst is seen in is a type of mesenteric cyst arising from the mesentery. This is a root of mesentery. So from the root of mesentery, this is the mesentery like this attaching to the bowel. A mesenteric cyst is a cyst arising from the mesentery like this, known as chylolymphatic cyst, or duplication from the bowel known as enterogenous cyst. There are two types of mesenteric cyst, chylolymphatic cyst and enterogenous cyst. So chylolymphatic cyst will be easily treated by enucleation. It can be treated by enucleation. Enterogenous cyst needs resection of bowel. Yes, the triad is what they are asking. The triad is nothing but you can move this cyst perpendicular to the mesentery like this. You can move perpendicular to the mesentery like this, known as Tilloch's sign. So Tilloch's triad is made up of number 1, Tilloch's sign. Movement perpendicular to the mesentery is known as Tilloch's sign. Central dullness. 3, surrounded by resonance. Surrounding resonance. So Tilloch's triad, central dullness and surrounding resonance all together constitutes the typical Tilloch's triad. This is what we say it as Tilloch's triad. Please don't forget this thing. It's known as Tilloch's triad. Okay. So let's move on with the questions. So this is a Tilloch's triad. So what's the management of this condition shown in the image? Can you tell me what is this condition first of all? What is this condition shown in the image? What is this condition shown in this image? Actually, I have a session at 10 o'clock, another session on YouTube. So what is this condition shown here? It is a case of dermoid cyst. Please remember, it is an external angular dermoid. It is a case of external angular dermoid. It is external angular dermoid seen here. It may compress the skull. You have to do surgery. Surgical excision is a treatment of this type of dermoid cyst. So most common site of dermoid cyst is skull. It can be seen external angular, post-auricular, somewhere you can get this cyst. You have to treat them by excision, not osteomyelitis, this dermoid cyst. Okay. So what is this condition? These are all typical questions based on Bayesian law. When you open and read Bayesian law, there is a chapter on, typical chapter on Bayesian law on skin lesions. All these are taken from the skin lesion. Identify the clinical condition shown below is typically a carbuncle. This is a picture showing you a carbuncle which is common on the nape of neck. It is common on nape of neck. This is known as carbuncle. It is most common in diabetes mellitus patients. Okay, this is carbuncle. So this is a picture. Actually, there is a controversy whether this question came or that question came. So I put both the questions. This patient is having a non-healing sinus. Non-healing sinus with a multiple nodes. Typically, this is a case of tubercular lymphadenitis with a drainage of abscess. With a drainage of abscess, typically tubercular lymphadenitis. This picture is tubercular lymphadenitis. So these are all very basic questions. What is the procedure shown in the below image? Can you tell me what is the procedure shown in the below image? So I had Dr. Jokestar, I don't know whether you are attending FMGE classes in Unacademy. I have completely made one 8 hours image based session in Unacademy. So when you go and see all these questions, around 80 to 90% of the questions in Unacademy came from FMGE image based questions came from those videos only, those pictures only. So please utilize them. Definitely you will get benefit from them. So this is tracheostomy. Identify the procedure shown in the below images. Tracheostomy. It's a picture showing you tracheostomy. So 45-year-old lady presented with a rapidly enlarging breast lump, firm and mobile on examination with a basilated surface. That's a catch point. When you get a basilated irregular surface like this with the dilated veins, all of you know the answer. What is the answer here? Yes, what is that? I will be taking class live in my YouTube channel. Don't worry, bye. I will be frequently taking my classes in YouTube channels. So you can attend. You follow my Telegram channel. Whenever I go live, I will put it one day before that. Okay. So this is a Phyllodes tumor. Yes, this is a Phyllodes tumor. This is a Phyllodes tumor. Treatment is you have to go for excision of the tumor alone or simple mastectomy. An excision of the tumor or simple mastectomy is done for this type of Phyllodes tumor. Okay. There is not much big discussion. Phyllodes tumor is actually known as cystosarcoma Phyllodes. When you do the cut section of the Phyllodes, it will have a leaf-like appearance. That is why it is known as Phyllodes tumor. The treatment of Phyllodes tumor is no need to do axillary node dissection because there is no axillary nodes involved. Just simple mastectomy or even enucleation of that tumor alone is enough for Phyllodes tumor. Okay. So patient underwent breast cancer surgery. Patient comes to your clinic with the image shown below. On asking the patient to push the wall, you can see a winging scapula. Winging scapula. So Phyllodes tumor only you can see on inspection like this. Fibroadenoma you cannot see on inspection. Fibroadenoma will be very small. Even if it is a giant fibroadenoma, it will not be seen visible like this. So whenever you see a huge breast, go for Phyllodes tumor. Fibroadenoma will not be that much big in practice. Okay. So and also the fibroadenoma will have a smooth surface. Phyllodes tumor will have lobulated surface. Okay, lobulated surface. This is due to Bell's nerve injury. Please remember, this is winging scapula. It is not a surgery question at all. It is an anatomy question. Winging scapula is a finding seen in Bell's nerve injury. So Bell's nerve injury. If there is a thoracodorsal nerve injury, there will be latissimus dorsi palsy. Patient will be unable to rotate the shoulder medially. Medial rotation of shoulder will be affected in latissimus dorsi palsy. So this is actually a Bell's nerve injury. So please don't get confused in this. So Bell's nerve injury causes winging of scapula as shown in the image. Thoracodorsal nerve injury causes latissimus dorsi palsy. Medial and lateral pectoral nerve will cause adduction and medial rotation of limbs. Medial rotation of limbs will be affected in medial and lateral pectoral nerves. So these are the nerves commonly affected. So what is the type of hernia shown here? Anybody? What is the picture showing you? There is many students got confused whether it is a paraumbilical hernia or umbilical hernia. So please, why should you get a confusion? Umbilicus is normal. Can you see umbilicus is having a smiling shape? Umbilicus is having a smiling shape umbilicus. If it is like this with the swelling like this, it is not arising from the umbilicus. It is a paraumbilical defect. It is a paraumbilical hernia. If it is arising from umbilicus, you will have a picture like this. Umbilicus itself will come out. Okay, it will have umbilicus itself will come out in an umbilical hernia. This picture is a paraumbilical hernia. Many of them wrote it as umbilical hernia. As now it is paraumbilical hernia, not umbilical hernia. In a paraumbilical hernia, you can see the smiling umbilicus. Smiling umbilicus like this or like this. Okay, it is a paraumbilical hernia. Umbilical hernia, umbilicus itself will protrude out. Okay. A newborn is found to have herniation of bowel and liver through umbilicus, which is covered with a membrane. Newborn is found to have herniation of bowel and liver through the umbilicus, which is covered with a membrane. What is the diagnosis? When there is a covering membrane seen, it is known as omphalocele. When there is no covering membrane, it is gastroschisis. These are the two. So this you can see, it's an exampholos or omphalocele. This is gastroschisis. There is no covering membrane. So gastroschisis is more dangerous. The patients will have associated intestinal atresia and many babies die of short bowel syndrome. This gastroschisis babies, many babies will die of short bowel syndrome. This case of covering membrane is present means the word is enough to say this is an omphalocele. There is a covering membrane seen means it is omphalocele. A baby born with a scaphoid abdomen and breathlessness, X-ray chest is shown below. What is your diagnosis? A baby born with a scaphoid abdomen There is no breath sound heard on left side, and when you are going and examining by X-ray, you can see the entire bowel loop on the left side. This is a congenital diaphragmatic hernia. What is the name of this congenital diaphragmatic hernia? What is the name of this hernia? Yes, what is the name? This is known as Bogdalak hernia. Please don't forget, this is Bogdalak hernia. This is a Bogdalak hernia. So this is a very important point I want you to remember for your exam. This is Bogdalak hernia. So X-ray of the patient after abdominal surgery is shown below. Patient is in state of ileus. He is in a paralytic ileus. They themselves are given patient is in ileus. The bowel loops are distended. What is the most common cause of paralytic ileus? It's a single liner question. Yes, it's a single liner question. So Morgagni hernia is very rare, boy. It's very rare. So only this Bogdalak hernia is common. Session time is going to end. That's why I wanted to complete the questions. So let me show you what is this Bogdalak and Morgagni hernia. You should not have a confusion between those two hernias. They both are congenital diaphragmatic hernias. So this is a diaphragm. There is a posterolateral defect. This is known as posterolateral defect. Herniation happening here is known as Bogdalak hernia. Bogdalak hernia is most common on left side, and it is most common overall among all. So Morgagni hernia is a hernia seen anteromedial defect. What is the name of this defect? It is anteromedial defect known as Larry's space. If a hernia happens through this Larry's space, it is known as Morgagni hernia. It is most common on right side. Most common content is transverse colon. In Bogdalak, most common content is stomach. So these are the basic points. You should not forget about these two hernias. Please don't forget about these two hernias. Okay. So this is a paralytic ileus. The condition is known as hypokalemia. Hypokalemia is the most common cause of paralytic ileus. You can see enormous number of questions from surgery. A bedridden patient post-surgery developed a low-grade fever. You can see its patient developed a low-grade fever and pain and pedal edema on 5th post-op. It's a very classical question of DVT. So please remember, DVT only can cause low-grade fever. All other things given here will cause high-grade fever. Necrotizing fasciitis and cellulitis can cause high-grade fever. DVT is a cause of low-grade fever. Every clinical topic has a catch point. If you know the catch point, you can answer any number of questions. So low-grade fever is a classical point for DVT. Okay, please don't forget this question. So what is this? These are all questions from urology. You can see a snake appearance. Cobra snake appearance at the tip. Cobra snake appearance. What is this known as? It is known as cobra head appearance is known as uretrocele. Please don't forget this. You can see the picture showing you cobra head appearance known as uretrocele. So I am showing you some interesting deformity. Many deformities you would have discussed here and there, but one deformity you would have not discussed, that is shepherd crock or fish hook sign. So what is this condition? Can somebody tell me what is, where will you get this appearance? You can see the ureter is having a fish hook sign. Looks like a fish hook or a shepherd crook. Can you see the shepherd crook here? You can see the shepherd crook very classically shown here. This is a shepherd crook. Like this is a shepherd crook. Where will you get this? Very good, boy, good, very good. It's an excellent. It's seen in retrocaval ureter. Ureter will be running anterior to IVC. If it runs posterior to IVC, it is known as retrocaval ureter. This is a finding seen in retrocaval ureter. Excellent. A patient sustains an RTA and brought to emergency department where he is found to have a pelvic fracture and there is a blood at the tip of meatus. What is the next step in the management? That's the question here. What is the next step in the management? A urethral injury. What will you do immediately? When a patient comes to your clinic with a urethral injury, the first important step, this is a basic baby MCQ. You should not make mistake. Suprapubic catheterization should be done. Because in a urethral injury, you should not try to put a Foley's catheter. If you try to put a Foley's catheter, you are failed in the exam. And if these are all classical questions in a MS general surgery exam. And the MS general surgery postgraduate, when he tells, I will put a Foley's catheter, he is failed. There is no more discussion. You should immediately put a suprapubic catheter. You should not put a Foley's catheter. If you put a Foley's catheter, you will damage the urethra more. Therefore, you should go for suprapubic catheterization. That's the point here for your exams. What is this picture showing you? What is this picture showing you? An X-ray showing you a yes. What is this? Yes, manhole patient putting his leg in the manhole is due to bulbar urethral injury. Boy, it's not due to this, it's due to bulbar urethral injury. So what is the condition shown here? It is due to bladder stones. Please remember, it is due to bladder stones. You can see a red opaque bladder stone. The most common bladder stone is calcium urate stone. The calcium urate stone is the most common stone, okay, in bladder. Identify the shock in a patient who had profound bleeding and has a CVP less than 5 cm. Low CVP, patient has a CVP low less than 5 cm. So low CVP in a trauma patient with a profound bleeding, no doubt it is hypovolemic shock. Hypovolemic shock is a cause of low CVP. Okay, answer is low CVP, not cardiogenic shock. In cardiogenic shock and all, you will have high CVP. Central venous pressure will be high. So from the history itself, you can see patient developed a shock following a hypotension, profound bleeding. That itself is a clue for you. You have to go for hypovolemic shock. Okay. A male patient presented with itching in the perianal region with soakage of his undergarment with a purulent discharge. Identify this condition. He is having a purulent discharge from this hole. This is anus. This is anus. This is a hole nearby. What is this? This is a perianal fistula. Perianal fistula will have continuous discharge. Okay. This is a picture showing you anus with an painful swelling perianal region. What is this? It is a case of perianal abscess. So perianal abscess. I don't know how many of your FMGE questions and how many of you have actually attended the exam questions, and how many of these questions are exact questions, I don't know. But all these questions are recall questions by various students. So this is a case of perianal abscess. Immediately I should put a cruciate incision to drain this abscess. I should put a cruciate incision to drain this perianal abscess. In future, this perianal abscess can land up as perianal fistula. A patient receives a renal transplant from his identical twin. This graft is known as what? Maybe this is the last question, I think. A patient receives a renal graft from his identical twin, that is known as, what is the answer? From identical twin. So please remember I for I. Remember this point. Don't get confused in the exam. Identical twin, I for isograft. I for isograft. Identical twin, isograft. Xenograft, gene. The gene itself is different. So gene is different means it's not a human to human. It is human to animal. Different species. Animal to human. Graft is known as xenograft. Don't get confused. It's a change of species. Autograft between the same person. Skin graft between taken from thigh and put on the shoulder like that. It's a skin graft is autograft. Allograft is between the same species. Same species. Okay. Same species. So thank you all guys. Actually this is a very small session. 1 hour session on Unacademy. This is the last session for me on Unacademy. So we'll be meeting you in some other platforms soon. Whereas in my own channel also you can meet me on T-Bar Surgery 6er is my Telegram link. You can follow me on that link. I'll be updating you all the things. Thank you all very much. Any doubt you have, you can always post. I couldn't take in-depth discussion, Magesh. Sorry, I just made a small outline because the time is not sufficient for me to discuss 25 questions. So soon I will make a detailed discussion of all these things and I will upload in the YouTube channels. So thank you all guys. Thank you Magesh. Thank you boy. Thank you all. So meet you soon in some other session. Bye.